301 we don't know.
Hello.
Yeah, Ashok. Ashok, are we ready to go?
Yeah, you're ready to go, sir.
Ready to go?
Yes, sir. Go ahead.
Just make me host.
Go ahead, sir.
Okay. Good evening, everyone, and welcome to the next session of Ortho-Onco classes from Tata Memorial Hospital, Mumbai. And I'm very happy to let you know that we are getting great response from these online classes. These classes are being organized by Musculoskeletal Oncology Unit, and we are using Zoom platform. In addition to that, I'm thankful to Dr. Ashok Sham, a dear friend who has Ortho TV facility where we are relaying live, and this is also live on YouTube as well. So if we take an average, last time we had about 860 viewership, which is great for a sarcoma class. So thanks to all the viewers. And a lot of people who had missed the earlier classes had sent me emails and WhatsApps request that they want to see it again. These recordings will be available on a YouTube channel in a few days. So we will be having it so that you can view them again and again. The YouTube channel will be on my name, and you will be able to see them, and we'll start uploading them from tomorrow onwards. Now, talking about today's class, this class will be addressing a very difficult region as far as musculoskeletal oncology is concerned. That is the pelvis region. We have Dr. Harsha. He is a senior fellow in musculoskeletal oncology in Tata Memorial Hospital. He's gonna present his seminar on pelvis, the indications for pelvic resections, type of pelvic resections, and how do we reconstruct them. I am the host, and Dr. Puri was supposed to moderate the class. He will join us in some time. So I think without wasting any further time, I'll request Dr. Harsha to share his screen and start the class on pelvic resections and reconstructions.
Thank you, sir. Good evening, everyone. Welcome to the TMH Ortho-Onco webinar. Today's topic is about pelvic reconstructions. To begin with, these pelvic tumors are very rare. So they are very difficult to treat. Why? Because these pelvic tumors are, the patient doesn't become symptomatic till the tumors becomes very large, because the pelvic cavity accommodates the tumor. So the symptoms will present late. And these patients are treated outside the tertiary center initially, and by the time they reach the tertiary onco care center, these tumors outgrow. So this will be a big challenge for the oncosurgeons to treat. And the surgeries itself are very, very complex, which includes a long surgical time and blood loss and everything. And resections are also very difficult in this type of tumors. So initially, the workup of the pelvic tumors includes the X-rays, followed by the MRI. On the MRI, we'll know the extent of the disease, based on which we'll plan for a biopsy, and followed by systemic staging according to the biopsy report. The details of the biopsy, how to do, and the staging procedures, everything were explained in detail by Dr. Gulia sir in the previous sessions. So I am not repeating that. And jumping into the indications of the pelvic surgery, the main indications are the primary bone tumors like osteosarcoma, Ewing sarcoma, and chondrosarcoma. Apart from that, the primary soft tissue tumors like retroperitoneal sarcomas, which are involving the pelvic bones, are one of the indications. And aggressive benign lesions like GCT and a huge ABCs can be an indications for pelvectomies. And apart from that, the metastatic tumors, although mostly we treat the metastatic tumors of pelvis with radiotherapy, but some tumors which are impending fractures, those are treated with the surgical indications. The relative contraindications for these pelvectomies are the metastatic status. So before we proceed to pelvectomy surgeries, there are huge, large surgeries. We have to see the metastatic status. Even though if you can save the limb, if it is multiple metastatic status, so that will be a relative contraindication to the limb salvage. And the response to the chemotherapy, neoadjuvant chemotherapy, has to be assessed. So if the tumor increases on chemotherapy, that indicates that it is a poor biology and poor prognosis for the patient. So one won't take the risk of undergoing such a large surgery on. And the hematopoietic malignancies like leukemias, lymphomas, and myelomas, so they respond very well with the chemotherapy and radiotherapy regimens. And we also have to consider the comorbidities the patient has and the performance status. As these are the very long surgeries, the patient should be fit from the anesthesia point of view for these type of surgeries. Coming to the anatomy, the bony anatomy includes the innominate bone on bilateral side, articulating with the pubic symphysis anteriorly and to the sacrum posteriorly with the sacroiliac joints. The bone contains mainly the ilium, ischium, and the pubis joining at the acetabulum area. And this pelvis, both upper pelvis and lower pelvis, host many vital organs, which are relating to the various systems of our body, like mainly the colon, the bladder, urethra, the reproductive organs like vagina, the spermatic cord, and the ureter. So one has to know the anatomy very clear, because these organs may be involved by the tumor per se, or these organs may be injured during the surgery while the dissection. So one has to be very competent about the anatomy of the pelvis before attempting for a surgery. And coming to the various neurovascular structures in and around the pelvis, like the external iliac vessels, the internal iliac vessels, and nerves like the femoral nerve, operator nerve, and sciatic nerve. All these structures has to be dissected with meticulous caution during the surgery. So one has to evaluate all these structures in the preoperative planning and should be aware of the relations of the tumor before proceeding for the surgery. So coming to the muscles which may be involved or which are to be resected during the surgeries include the anterior abdominal muscles like external oblique, internal oblique, and transverse abdominis. And inside the pelvis, iliopsoas, quadratus lumborum. And apart from this, outside the pelvis, the gluteus muscles, the abductors, the external rotators of hip, and anteriorly the adductors of hip are all come into play while during the surgical aspects. So the approaches, coming to it, the most common approach what we'll use for this pelvic surgeries is the ilioinguinal approach with an utilitarian incision. The incision extends from the posterior superior iliac spine all the way along the iliac crest to the ASIS. From there, it has two limbs, the medial limb and the lateral limb. So the medial limb goes along the inguinal ligament to the pubic symphysis, and the lateral limb turns posteriorly, crosses the greater trochanter, and then continues along the gluteal crease. So the tumors which are involving the acetabular region and the pubis region, so the incision may go along the perineal crease and turn backwards to join the gluteal crease. So based on this, there are after the incision will be like anterior flaps and posterior flaps. After erasing the abdominal musculature from the iliac crest, so we will see the iliopsoas muscle. Usually the iliacus muscle is kept as a margin over the tumor. The psoas muscle and the femoral neurovascular bundle, external iliac neurovascular bundle are retracted. Then we can see the femoral nerve, which has to be retracted medially. Then we will expose the greater sciatic notch inside, so that where we can free the sciatic nerve. And coming to the on the outer aspect, after raising the gluteal flap along with the gluteal muscles from its attachments, we will come to see the abductors. gluteus medius and minimus, which are kept as a margin of the tumor, and the external rotators of the hip, the sciatic nerve, the tensor fasciae latae, and sartorius and rectus femoris anteriorly. So after clearing all this, we'll expose the tumor. After that, we'll take appropriate bone cuts and deliver the tumor out without injuring the vital structures. So previously in olden ancient era, for this type of large tumors, complicated tumors, they usually followed the hindquarter amputation to get an oncological clearance. But due to the advancement of the chemotherapy and advances in radiological imaging and surgical techniques, now we are indicating limb salvage surgery for most of these pelvic tumors. So there are three vital or important structures like the femoral neurovascular bundle, the hip joint, and the sciatic nerve, which are important for a functional limb. So the rule is like, if you can save any two of these structures, one can attempt internal hemipelvectomy. Suppose we can't save, then one anyway has to go for external hemi only. Regarding the classification of internal hemipelvectomies, Enneking and Dunham has classified in 4 types. Type 1 resection includes resection of the ileum. Type 2 includes resection of the periacetabular region. And type 3 includes resection of the pubis and ischium. And type 4 includes the resection of sacrum. Based on the extent of tumor, so there may be combination of these type of resections like the type 1 plus type 2 or type 1 plus type 2 plus type 3 or type 1 plus 2 plus 3 plus or minus sacrum based on the margins and oncological resection. So these are the pictures. So the surgeon faces this kind of situation after the resection, after saving all the important vital structures which are essential for the limb to function. So now the question arises for the surgeon how to reconstruct this complex type of defects so that to give the patient a good functional outcome. So before proceeding to that, so the most important part is the planning, the preoperative planning. One should evaluate the imaging, the MRIs and X-rays very carefully. They should clearly know, they should see the contrast images and clearly know the extent of the disease and how much overhang it is having and what are the structures it is involving. And one has to plan the margins and one has to know the extent of disease and the margins and amount of resection and the amount of bone remaining. So this is not these complex surgeries are not a single surgeon decisions. So this tumors itself involves various systems. So a multidisciplinary meeting discussion is very helpful and very essential. So taking guidance from the senior faculty and from various departments, discussing with them what are the planes, what are the organs involved. So these all will come to a conclusion that what is the anatomical defect we are getting after the resection with good surgical margins and what is the functional deficit the patient is going to face after these resections. So apart from that, we have to consider the patient factors also while thinking of reconstruction. Most important is the age. If we are operating for a pelvic resection in a younger age, so we should keep in mind that these patients going to live for 50 to 60 years. So the reconstruction what we are attempting should be like lifelong. Suppose for resections involving the 60-year or above age group of people, mostly they are sedentary group, the reconstruction options for them are little different. And also we have to take into consideration the occupation of the patient and the physical demands what the patient wants and the expected survival with the respect to histopathology and staging, and the affordability of the patient is also very important because the reconstruction options comes at a variable cost. And the patient counseling, lastly, before taking for surgical procedure, we have to explain the patient regarding the disease status, and what are all the reconstruction options available, and what are the pros and cons, what are all the advantages and disadvantages and cost benefits of this in detail to the patient. And we have to take the consent for all the complications before we are taking the patient for the theater. So now entering to the topic proper, the reconstruction of pelvis, we have various options. The first one is no reconstruction itself, and biological reconstructions and non-biological reconstructions. Now I will explain you in detail with respect to the type of resection, what are all the options available. So for a type 1 resection, which involves only iliac resection, so these surgeries will take less time, and these type of surgeries will have good prognosis. Why? Because we are preserving the hip joint in this type of reactions. So the native hip will be preserved, and the patient will enjoy the hip ROM of the native hip. The only issue is there will be a discontinuity of the pelvis. We can leave the pelvis as such, but there may be some amount of shortening on the post-operative period. So the reconstruction options available include the biological options like allograft or autograft. The same ipsilateral fibula or autograft from a bone bank can be taken, and we can bridge the gap between the in the pelvic ring, so that the gap will be the void will be finished, and we can use a few some implants like plates and screws to fix these autografts or allografts. So the advantages will be there will be minimal shortening, and the disadvantages will be these grafts may fail to unite later, or there may be an infection due to this hardware which has to be addressed later. The other type of is non-biological reconstruction, which doesn't use any grafts here. We use only rods and screws. Screws are inserted on the sacrum and on the acetabular area and are connected with the help of rods, and cement is used to fill the void. So these type of reconstructions are very useful when we require a post-operative radiotherapy, which hampers the union of grafts. But it comes with the disadvantages like infection, loosening, and mechanical failure, which you can see in the next figure. The screws got broken and the plate rods got broken. So which may require revision surgeries. So this is a paper publication from China who had evaluated the outcomes for the resection of type 1 or 1+4 resection with rod and screw systems. They have concluded that for younger patients who doesn't require post-operative radiotherapy, the bone grafts gives a good option, the biological thing. Or for an elderly people who requires radio, or patients who requires radiotherapy, the non-biological options like rods and screws are better. And even with the rods and screws, 2 rods and 4 screw fixation gives a better mechanical outcome when compared to single rod and screws fixation. Now coming to the type 2 resections, which involve the acetabular resection. These are most complex surgeries of all the pelvic resections, because it will entail the removal of the entire hip joint, and this may take a long time, and there is a lot of blood loss in this type of resections. And the options available are again biological and non-biological. Coming to the biological resection reconstructions, the most commonly indicated is the flyer hip. That means no reconstruction, just leave the femur hip in the way there itself. And another mode of reconstruction is the transposition orthoplasty, where you can see clearly here the femur is attached to the sacrum or ischium with the help of a Prolene mesh, so that the femur is little bit relatively stable. And the advantages of this type of reconstruction is, so it will allow a free movement around the hip joint, and the patient can be able to sit and squat, which are most important in our Indian population setting. And the disadvantages include there may be shortening and instability of the hip, but patient generally after a long term they will be used to this type of shortening and instability, as we will give him a heel raise and we will teach them the exercises, core strengthening exercises to combat the instability. And the next option is arthrodesis, where the femur is arthrodesis with the ischium or ilium, iliofemoral arthrodesis or ischiofemoral arthrodesis. So the hip is stable here. So this will be mainly useful for young adults who are manual laborers or who require a stable hip. But the disadvantage is there may be shortening, and there may be a non-union of arthrodesis or due to infection due to the hardware inside. And the third one is again biological use of allografts or sterilized autografts by using either ECRT or cryo or pasteurization. So mostly by using this type of reconstruction, the anatomical hip can be restored. So there may not be any shortening or instability, but due to the hardware and allograft, there may be issues like non-union or infection and mechanical failure of the implants, and which may require multiple revision surgeries. So coming to this publication from India, from Madras Medical College, Chennai. So they have compared for this type of type 2 and 1 resections, the process versus orthodesis and no reconstruction. And they concluded, the authors concluded that on the long-term basis, the no reconstruction or orthodesis group has a good satisfactory outcome with 75% over the long term. Even though the process may give early result, early good results, but a long term they are subjected to many revision surgeries and comorbidities. Coming to the non-biological options for these type 2 resections, the saddle process. Initially, during in the early decades of its invention, many of the surgeons used this saddle process, but later it going into vain because of its associated complications, mainly multiple recurrent dislocations, loosening of the process, fractures, and migration. The only advantage with this process is its modularity, so that the shortening can be resolved with this type of process, but it has its own complications. The next is the non-biological is a process, it's a custom-made process which you can see in the figure, and it is costly when compared to any other reconstructive measures, but it is also having its own prosthetic complications like loosening, implant breakage, migration, and infection. The other option is pedestal cup or ice cream cone process. The early results of this type of reconstructions are very good because near total hip reconstruction was done. But later, as the days progress, these process have end up in multiple complications like multiple dislocations and revision surgeries and followed up by infections. And many patients have undergone revisions and removal of the process due to these recurrent complications. And the other is a composite process, which includes we use either an allograft or an autograft combined with the process, total hip. So the complications here include the fracture or non-union of the grafts and the routine prosthetic complications like loosening or infection. So here is the study from Royal Orthopaedic Hospital, Birmingham, the Gramer et al. They have, regarding the patients, in 18 patients, they have used irradiated bone autograft for pelvic reconstruction. They have only observed out of 18, only 3 patients had complications, that 2 infection. Apart from that, the outcomes were satisfactory, and the authors concluded that this type of modality of pelvic reconstruction is suitable and is applicable for this pelvic reconstructions. And the second, this publication from China has compared outcome, has revealed the outcomes of hemipelvic of femoral head autograft. They are evaluated on 18 patients, out of which there is a 40% complication rate. The main complications include the dislocations and deep infections. This is a publication from Netherlands with the outcomes of endoprosthetic reconstruction with the pedestal cup. They have 19 patients in total, out of which 15 patients had complications. The most common complication is recurrent dislocations and followed by aseptic loosening and infections. The authors concluded that because of this poor results, they avoid caution of using this pedestal cup as a reconstruction option. One more paper from ROH Birmingham regarding the ice cream cone process. They have used in 27 patients and the complication rate is 37%. The most common being dislocation again, followed by deep infections. Even though the authors concluded that even though the early outcomes and early functional results are good with this type of process, on the long term, this process showed a high rate of morbidity. Now coming to type 3 resections, these type 3 resections are relatively easy. They will take lesser time and the outcome is good because the biomechanical axis is maintained, the hip joint is intact, and the pelvic ring is not disrupted in the weight bearing axis. So ideally, no reconstruction is required for this type of resections. But as it is very close in vicinity to the bladder and urethra, there may be a high chances of injury to bladder and urethra in this type of reconstructions. And as we are injuring the inguinal canal and the anterior abdominal musculature during the dissection, there are high chances of hernia. So it is always better to take an urology consultation or neurosurgeon consultation before proceeding to this type of surgeries, so that there may be helpful intraoperatively if there are any anticipated injuries to these visual structures. And coming to the combinations of resections, there may be like type 1 plus 2 plus 4 as you can see in the picture. These can be reconstructed with various options like flyer hip, transposition arthroplasty, or autograft, allograft, which I explained previously. And in type 2+3, the same options which are applicable for type 2 are also applicable for this type of resections. Coming to the total hemipelvectomy, which was indicated in some huge pelvic masses. So the entire innominate bone will be removed along with some part of the sacrum if required. So the most common type of reconstruction, usually we use the flyal hip or a transposition arthroplasty, where we use the mesh to anchor the femur head to the sacrum. In some parts of the world, they are using this process, which I have shown you in the figure. These are called as hemipelvic process. It's a custom-made process which can come. And we can also use allografts or irradiated autografts for the reconstruction of this type of resections. So this is a paper from publication from China, where they have reported outcomes of 50 patients reconstruction with the modular hemipelvic endoprosthesis. So the complication rate was 48%, but the authors were saying the most common complication is only superficial wound infections, which were settled gradually, and deep infections are only 14%. The authors concluded that this type of reconstruction is better for an improved function with an acceptable complication rate. In a nutshell, if you see all this type of reconstruction, the pseudoarthrosis or transposition arthroplasty, the flare lip, there will be shortening and instability, but the complication rate is very, very minimal, and it is very well acceptable in the Indian population setting, where we have a habit of to sit, squat and cross leg. And this shortening can be combated by giving a heel raise and good postoperative physiotherapy. And coming to saddle process, the shortening can be corrected, but this process had high chance of failure due to multiple dislocations and infections. And arthrodesis, there is some bit of shortening, but it is a stiff hip, which is mostly useful in the young patients, but the complication includes non-union. Coming to the autografts, allografts, and endoprosthesis and composite prosthesis, by near total reconstruction of the hip, the shortening and instability are addressed, but there is a high rate of infections, failure, and high cost associated with it. So our study from TMH Mumbai, which was published in 2014 by Dr. Puri et al., this largest series, which includes 103 patients, and we have not the various reconstruction options we used were, there is no reconstruction done for non-periacetabular resections. And among the periacetabular resections, the various options we used were pseudoarthrosis, arthrodesis, ECRT, and pelvic prosthesis. So the authors concluded that the complication rate is only 18%, and they attributed this low complication rate is mainly due to majority of the patients undergoing either pseudoarthrosis or arthrodesis. So this is a systemic review by Robert J. Wilson, which includes 22 studies. So the authors mainly evaluated 4 domains like mean survival, mean non-oncological complications, and mean non-oncological reoperation rate, and the musculoskeletal tumor scoring. So the authors concluded that no reconstruction type outperformed all the reconstructions in all the domains. In all the domains. So they concluded, in a nutshell, I want to summarize all this literature. The no-reconstruction type or the resection arthroplasty or the pseudoarthrosis, which we reconstruct with the Prolene mesh, the femoral head is anchored to the pelvis. Although in the initial post-operative period, there may be some complications, but on the long term, it gives a good outcome to the patient, functional outcome. So regarding the post-op rehabilitation, usually the patient will be in bed for 6 weeks along with an abduction pillow and derotation boot. And DVT prophylaxis has to be given to prevent DVT, and second hourly position change and bowel and bladder care has to be taught to the patient in detail. Now coming to the metastatic pelvic bone disease, usually many of the oncologists or surgeons treat the pelvic bone metastasis with radiotherapy. There is a very little literature available, but this review article from Daniel A. Muller has classified this pelvic bone metastasis and has prepared the treatment algorithms. So how to address the pelvic metastasis. So there are 4 classes. The class 1 includes a solitary metastatic lesion with an interval of 3 years from the site of detection of primary, and the primary being with a good prognosis, like well differentiated thyroid or prostate or breast or clear cell renal cell carcinoma or lymphoma or myeloma. And the class 2 includes the pathological fracture in the periacetabular region, and the class 3 includes supraacetabular osteolytic lesions with an impending pathological fracture, and class 4 includes multiple osteoblastic and osteolytic lesions. So the class 1 patients which are having good prognosis with only single metastatic lesion with a good primary, usually we treat these type of lesions as a primary bone sarcoma. So we achieve for a wide resection and with the reconstructions which I explained already in detail in the previous sections. Now coming to the class 2 and class 3 sections, and again the others divided into 4 defects. The Harrington 1 defect, which is the subchondral bone is intact and it is preserved. For this type of defects, we usually use curettage. So curate the complete lesion outside and use cement to fill the defect and followed by a conventional THR, total hip replacement. In Harrington type 2, the medial acetabulum was eroded by the tumor, but the superior part of the acetabulum is intact. In this type of lesions, what we use will replace the hip, but with the help of a reinforcement cages or mesh, we will use to reinforce the acetabulum. In type 3 defects, where there is both superior and medial wall, both are eroded, the acetabulum will be highly unstable. So in this type of lesions, what we do usually is the Harrington's procedure. This is the picture which describes the Harrington procedure, where we will use multiple Steinman pins from the ileum to the ischium, so that to create a base, a foundation for the acetabulum, over which we will keep the cement, and the above which we will reconstruct the hip with the total hip replacement. In Harrington's type 4 defect is the complete collapse of the acetabulum. So the conservative procedures which can't be done. So in this type of defects, we again go for massive resections and mega prosthesis or saddle prosthesis or pseudo arthroplasty. Coming to the class 4, where there are multiple metastases on the pelvis, usually we won't attempt a surgical treatment in this type of lesions. We will go for radiotherapy or oncological treatment. If at all the pain persists, then we will go for a minimally invasive ablation techniques like acetabuloplasty or cryoablation or radiofrequency ablation. So the future of these pelvic reconstructions include the 3D printing or 3D pelvis model and navigation surgery. These 3D implants are gaining popularity nowadays because they are printed and they fit exactly very well after the resection. So the defect or the void which was created after the resection is very well filled with this type of 3D implants. And again, we are using a patient specific instrumentation for them. The jigs are available, so the resection will be easy with this help of the patient specific instrumentation by using these 3D printed implants. And these 3D printed models of the pelvis of the patient's tumor, so that on which the surgeons can practice the cuts and the various techniques on these models itself. Last but not the least, the navigation is gaining popularity. We in our hospital also were doing navigation assisted surgeries, and we personally saw the advantages with the use of navigation. So these pelvic tumors, which are very huge and which are in the close vicinity to the very visceral structures like vessels and visceral organs, and sometimes there may be a lot of overhang of these tumors. So usually the surgeons will fear, so they will go for an wide margins. Wider means more than extra margins required, because so in this type of situations, the navigation will help a very lot. So in the navigation, we will map the tumor, we will map the vessels, we will map the various visceral organs. So the computer system delineates the various red zones. So it will give very good access to the surgeon so that he can take the cuts very precisely without injuring the vital structures with a good, safe and oncological margin. Not only the computer assisted resection, but navigation assisted reconstruction are also coming nowadays, in which the same navigation principles or the same navigation plan which we have used for the resection in the body, we use the same plan on the allografts outside, so that the exact anatomical allograft has been prepared, which is very much identical to the specimen which was removed, and it can fit very precisely into the body. The fixation will be easier. So there is no hard and fast rule that this type of reconstruction is suitable for this and this type of reconstruction is superior. It is the surgeon's choice, and it depends on the patient factors. Finally, the proper planning, preoperative planning, and proper patient selection with the teamwork gives us an acceptable and functional outcome on a long-term basis. Thank you.
Thanks, Harsha, for a nice overview of pelvic anatomy, resections, and reconstruction. We have already been joined by Professor Ajay Puri, so I would request him to switch on his video as well. We also have Dr.
You just
Yogesh.
need to hear my voice, Ashish. You don't need to see my face, so it's all right.
It's okay, sir. It's better to see you.
No worries. My apologies to all. I was supposed to moderate this session, but we had a last-minute parallel session from the department for all residents, in fact, from the hospital because of this pandemic. So I was occupied there. So my apologies again to everybody for joining late.
We also have Dr. Yogesh Panchwag as our external expert. Yogesh, can you join in as well?
Yeah, I'm here, Ashish.
Okay, so great. So we saw the overview of pelvic anatomy, resection, and reconstruction. So I think I will take few questions and will ask Dr. Puri and Dr. Yogesh Panchwag, and we now have Prakash Nayak also joining us. So Dr. Puri, in your practice, what sort of preoperative planning, because pelvic surgeries are very complex surgeries. So what is your protocol that in preoperative planning, what are the things which you really take care of, and how do you plan these cases for pelvic resections?
I think it's not just preoperative planning. It's the correct choice of the patient. It's not that every patient, you're not looking at the pelvis in isolation. You're looking at the entire disease in its entirety, the patient's comorbid conditions, and that specific lesion. So planning begins with actually choosing the right patient also for surgery, the right stage of the disease. Eminently resectable pelvic tumor, let's say 14 chest metastasis, is not to me the ideal case for doing a pelvic resection, no matter whether it's easy or not. So it's choosing the right patient. As far as procedure goes, though I entered late, I have been privy to seeing Harsha's presentation earlier. So I know that he's delineated the vital structures and how you have the 3 strikes rule, where 2 out of those 3 strikes, if they're involved, it may not make sense to do a particular resection. So in the preoperative planning, as is the rule for everything, your margins are determined by the pre-chemotherapy extent of the tumor, because post-chemotherapy, especially in Ewing sarcomas, which is a large number of pelvic tumors that you will see, your tumor may seem to shrink and you may be tempted to do something that is less than optimal. So your margins need to be marked out on the pre-chemotherapy images. You need to be able to identify the structures which are close to it, which you would need to protect. In the pelvic area, it's generally the vessels. Occasionally, if it's in a type 3 or something that involves a type 3 resection, it's also the bladder, the prostate, and the urethra that you need to be careful of. You need to also mentally have a plan as to what is going to be the reconstruction that you use. Across the world, there have been various ways in which we do reconstruction. It's not only a combination of what the surgeon wants to do, but it's actually sitting down with the patient, talking to the patient about what their expectations are, what are their activities of daily living, and then taking a call, what would be the optimal reconstruction for this patient, balancing oncologic clearance, function, chance of morbidity, chance of complications, all that comes into consideration. And then it's also the surgeon's experience. So all of us start doing pelvic surgeries for the first time sometime. It's nice when you have in your initial surgeries, if you have someone who's been in this field earlier, someone who's there to sort of guide you and advise you when you do these and as you gain your own experience. So you need to combine all these, look at it in a more holistic pattern, then rather than just look at that one pelvic lesion when you plan your surgeries.
Dr. Panchwag, my next question is to you, and I would request you to elaborate what sort of extra preparations you do in addition to operating a regular sarcoma in extremities. What are the extra preparations you do for planning or preparing a case of pelvic resections? What extra precautions and what extra preparations?
Yeah, okay. So as far as the anatomical site is concerned in the pelvis, and most of the times as it happens, we have a lot of patients who present to us at a very late stage. So we are expecting tumors which have a big extraosseous components. So we are looking at a very major surgery and with a lot of morbidity that comes along with it. So basically, you have to be prepared for everything. You have to be prepared for massive blood transfusion. You have to keep adequate blood ready. Sometimes depending upon the tumor location and the involvement of the critical structures around, we have to keep the other specialties on standby or actually get them involved during the surgery preoperatively as well, and that could involve the kind of gastrointestinal team or the plastic surgery team to plan some flaps if required maybe, and the GUs, the genitourinary services. So these guys will have to be kept in the loop. Maybe sometimes the vascular surgeons may have to be kept in the loop. We have, these sessions where we would actually sit together and plan the surgery preoperatively, discuss all the things, decide upon the sequence, who's supposed to come in at what particular juncture and do what type of a job. All these things we have to sort of plan it out beforehand. We also have a policy where a very massive blood transfusion is involved in a pelvic resection. We do an, autologous transfusion. So we ask the patient to donate his own blood beforehand, 2 or 3 weeks before the surgery, if that's possible, and that's possible from the point of view of chemotherapy, if anything has to be given to that particular patient, and then keep this blood ready at the time of surgery. Obviously, other things like ICU planning and keeping the necessary equipment and implant and instruments ready at for these particular surgeries is also critical. So that is what I sort of think on a very rough basis how we go ahead and plan these particular cases.
Thank you, Dr. Panchwag. Yeah. So basically, to summarize what Dr. Puri and Dr. Panchwag said, that pelvic resections and reconstruction are difficult surgery. They're a big challenge. There's a long learning curve in doing these surgeries. We need to choose our patients very, very carefully. And in addition to our regular preparations for our sarcoma surgeries, we need to involve multiple teams from various departments, need to be prepared regarding the blood loss and ICU care, high complication rates in terms of flap necrosis, wound necrosis, infections, and rehabilitation, which is going to be over a period of time. So maybe having a good psychological counseling before the surgery. So all these things matter a lot. Dr. Panchwag, just one line in addition to this. How does your counseling goes? Because we have heard many of our colleagues who face difficulty in counseling these patients because these surgeries are pretty complex. And few of these patients who also and especially of Ewing sarcoma patients who have another option of getting the local treatment done by definitive radiotherapy. There is a dilemma in the mind of a lot of colleagues. So how do you counsel these patients, and what specific things you always keep mentioning in your counseling for pelvic resection and reconstructions?
So just to keep it simple, whatever consent we are going to take from the patient, everything and all of that has to be explained while we counsel the patient preoperatively for these surgeries. Initially, especially in a private practice, we have a tendency of sort of not telling everything to the patient. well, I'll suggest that that is not to be done, and be very frank and clear, because anything can happen. In a few cases, you may land up having intraoperative massive blood loss, and sometimes, we may lose the patient on table. So if necessary, even a death on table death on table consent may have to be taken from the patient and the relatives. So there's nothing to be hidden from the patient and the relatives as far as the counseling goes, and whatever difficulties you envisage in these particular cases has to be told to the patient and the family, and an appropriate consent has to be taken. That's
Okay, great. Now, my next question is to Professor Puri. Dr. Puri, hello, Dr. Puri.
Yeah, sure. Go ahead.
Yeah. Dr. Puri, I want to ask you, there is a question which is asked by one of the delegates who's attending, that do you prefer CT or MRI or both for planning of these patients? Preoperative planning.
So I think it's not just the pelvis, but we are all quite comfortable with an MRI that gives us adequate amount of information about this. Yes, there will be an X number or a small percentage of cases where we may prefer a CT scan along with that. For example, sometimes in chondrosarcomas, a CT scan is better. So it's not a blanket rule that you will do both an MRI and a CT or only an MRI. But I would say, as far as our practice is concerned, the large majority of patients can be evaluated by radiographs and MRI alone. And there could be a small number in which we would do an additional CT if we were planning something sort of, we thought that would give us additional.
So what will be those indications where you need additional CT scan specifically to plan the type of?
Okay, so sometimes it's chondrosarcomas. Sometimes when we are unclear as to whether there is a break in the articular cartilage or not, in where the acetabulum is concerned, is the hip involved or no, in those cases, sometimes we get an additional CT scan done with thin volume cuts to make certain that it's not breached that, and we can actually do an adequate enough pelvic resection without resecting the proximal femur. So these would be off the top of my head, the main indications that I could think of.
Okay, Dr. Puri, I have got one special request online. People want to see your yellow T-shirt, so they feel that you should be visible, and you should have your video on.
Yeah. I can't refuse you. That is my problem. I can't refuse you. So there I am.
So we have Dr. Chetan Anchan also with us, and senior orthopedic oncologist.
Ashish, my just one request is, I can see a host of lot of questions. So maybe if you could take them, sort of sieve through them, take them one by one, and we could sort them out rather than me having to type text for all of them.
No, you don't have to type text. I'm taking them one by one. So that's why I took one of the questions where I asked you about CT and MRI. And the next question is to Dr. Chetan Anchan. Dr. Anchan, we have a question here, and someone has asked us that how do you take the call that, how many lung metastases, is it worth to operate this patient or not? Or having that metastasis will make you change the type of surgery you do or the type of reconstruction you do. So how do you take the call in metastatic patients? And will it differ depending upon the number of mets?
It depends on what disease we are dealing with in the first place. I mean, whether we are dealing with, osteosarcoma or Ewing sarcoma. In Ewing sarcoma, we are more liberal with the metastasis thing, because after chemotherapy, some of them may disappear, they may stabilize. We can even use lung bath to, take care of the lung metastasis. In such a situation, we also take into consideration the patient's age, their response to treatment, the neoadjuvant treatment, before we decide on surgical management. So upfront, if the patient is metastatic, I may not commit about what kind of surgical management we'll do. It all depends on how well they respond to the chemotherapy. That is when I would assess the patient again and then counsel about the role of surgical management in pelvic tumors especially.
Okay, great.
So Ashish, I'm going to add something to this.
Yeah,
I think it's going to be based on each individual institution's practice. Nobody is going to be able to put a number on the fact that, 4 metastases and less I will operate, 5 I will not operate. I think all of us agreed that 20 metastases, none of us will operate. But whether it's a question of 4 or 5 or 6. It's going to be each individual experience of a surgeon. And we have seen that more than 4 metastases, generally the patient doesn't do well. You also have to balance what is the primary volume of the disease. If it's a large volume tumor with 5 metastases, that's obviously going to do much worse than, say, a smaller volume tumor with 2 metastases on either side. So it's very difficult to put an objective number. This comes with experience and more of subjectivity.
Great. So I'll just summarize what Dr. Anchan and Dr. Puri said, that these are complex surgeries. You are doing a very big surgery, which has a lot of risk involved in the surgery. As Dr. Panchwag also mentioned, the kind of preparation you need. Obviously, we all know that with metastasis, the prognosis in sarcomas goes down dramatically. So you need to sort of custom made your plan, whether it is the type of resection or reconstruction for each and every patient. And depending upon patient physiological health, patient age, the number of the metastasis and the infrastructure available, you need to take a call and then go ahead. Now, my next question is to Dr. Puri. And we have 2 questions here which talks about surgical margins. And someone has asked that Puri sir said margins decided on pre-chemo imaging, whether it holds same for pelvic Ewings or not. That is number 1. And someone also has asked about that how do you decide the adequacy of margin in pelvic tumors, and do you rely on frozen sections? So these 2 questions I'll request Professor Puri to address.
Okay, the question of margins, irrespective of disease, irrespective of whether it's the little toe or the pelvis, is always pre-treatment margins. It doesn't change whether you're treating the little toe or the pelvis. It doesn't change whether you're treating an osteosarcoma or a Ewing sarcoma. Your aim is to remove every disease that was present prior to treatment, because though post-treatment the disease may have shrunk, you are not getting a microscopic evaluation of the disease. What you are getting is a macroscopic what the image has shown. So I don't think that changes. Your second question was, how do you, frozen section. I mean, frozen section, we have stopped doing frozen sections now as a routine, because frozen section was there earlier when the quality of imaging was not that good enough and there was possible a doubt as to what the extent of the tumor is. With today's quality of imaging, I don't think there is a routine role for frozen section. The only time when you will do a frozen section is when you as a surgeon believe that you have come too close or possibly violated margins and you want to reconfirm because you may want to excise more intraoperatively. But if your preoperative planning has been good, you have planned them correctly on the correct preoperative imaging, I think there is little role for frozen section today.
Great. So I think Professor Puri has very nicely elaborated. Just one point to add to this is that the way we talk about conventional margins in extremity, like taking a couple of centimeters or 3 centimeters, that is not possible in pelvis because of anatomical constraints and the important visceral structures available. So that's why your planning and your reading of your imaging has to be very accurate, and you need to put a lot of time into planning these cases, and the execution has to be perfect. So you may not be like a couple of centimeters, but maybe about a centimeter and a half. And that's why it is very important to have that experience under your belt so that you can excise these tumors completely. Now,
Another practical point is that in chondrosarcomas, the disease is a more permeative disease. You have to be more careful of margins, and that is the one entity where you have no backup of any adjuvant, either chemotherapy or radiotherapy, which would help you sterilize your margins in case you were wrong. So in chondrosarcomas, be more careful, take more margins than what you would otherwise sort of anticipate saying by going too close, because these are permeative disease and you have no backup of any adjuvant.
Yeah, and I think this also answered that question where somebody was asking about Ewing sarcoma, whether you take preoperative MRI or not. But obviously, when we look at chondrosarcoma with permeation, we are very wary of getting a positive margin, much more than any other tumor. So my next question is to all of the faculty members, Dr. Panchwag, Dr. Puri, Dr. Anchan, and Dr. Prakash Nayak has also joined us just now. So Dr. Panchwag, what kind of incision do you prefer? position of the patient and incision. What kind of incision do you prefer? Because a few people look at having a classical utilitarian incision, and some people modify it because of associated complications. So what has been your experience, and how do you decide?
Well, yeah. So in the beginning, as was our practice, we were using that classical utilitarian T-shaped incision. But as you rightly pointed out, there were a lot of complications, wound healing complications, as far as the triponter was concerned. And hence, we have now modified the position. Actually, depends upon where the location of the tumor is. But typically, it would be something like anywhere between a sort of a semi-lateral or a semi-supine kind of a position with the help of lateral supports. The limb is drape free, and nowadays we are very comfortable using a single incision that runs along the iliac crest and extends along the inguinal ligament up to the pubic symphysis. And if it's a type 3 resection, then we extend it down medially onto the thigh and around the inferior pubic ramus. There is only a problem if you have to resect the humeral, the femoral head along with the acetabulum, that is type 2 plus H type of resections. Then sometimes it's a bit of a struggle, doing the intertrochanteric osteotomy and then reaching the osteotomy level of the ischium. So there's a little bit of a struggle over there, but with sort of a little bit of an experience and retraction, we are able to do it in a single incision itself. So nowadays, all of our pelvic resections have been through a single incision.
All right, so it's exactly what Yogesh said. The position, I'd say, is more of a floppy lateral that allows you to make the patient both supine and prone to the maximum extent. Because very often when you're doing a 1 plus 2 plus 3, you need to have the patient both almost near supine and almost near prone. It also will depend largely on the segment of bone that you are excising. If it's only a type 1, obviously you don't need to really make the patient go up and down. So it depends on what is the area of bone that you are excising. Regarding the incision, I agree with Yogesh, but again, I feel that exposure is the most important thing when you are doing pelvis. So I myself still am not reluctant, if required, to use the T-shaped incision. Yes, I would do majority of my surgeries through a single incision, but there are times when I have still had to resort to a T-shape because I feel that the exposure that has given me for that particular case is better. You have to be careful how you handle the triponter, but a good exposure is the baseline or the cornerstone of getting adequate oncologic resection in the pelvis.
Ashish, you are not audible.
Hi, all of us are muted. Ashish is muted, especially.
Yes,
it's
Dr.
pleasant
Chetan,
experience, but I think here we don't need that.
Yes, Ashish.
Yeah, your preferred incision, do you
It's a single incision. I mean, I don't remember when I last, used a Y incision. So,
okay.
But yes, that always remains as your backup, as Yogesh rightly pointed out. Whenever you are going a bit way down in the shaft, you can reach up to the capsule, but beyond that, it is certainly a struggle. So where you need to resect the proximal femur, you may extend it, and as Dr. Puri said, your access is very, very important. And for that, if we have to modify your incision, you should be definitely prepared to do that.
Great. Prakash, are you around?
Yes, I am.
Hi, Prakash. So I will change the question. I will change the question. Okay. So what are your views regarding reconstruction of defects after type 1 or P1 resections?
Reconstruction after P1 resections.
Yeah.
So I would prefer not to reconstruct P1 resections. And
any specific reasons? Any specific reasons?
So a few reasons. One, in most patients with a P1 resection, the acetabulum being intact, a lot of the structures that go from the sacrum all the way to the pelvic floor and the ischium remain intact. The pelvis is relatively stable. Oftentimes the pelvis collapses on its own to bridge the gap and maintain continuity, soft tissue continuity between the sacrum and the iliac cut. And the added morbidity of reconstruction is not justified because there is a very good function even in patients who do not undergo any reconstruction for type 1 defects.
Chetan?
Yes, no reconstruction for type 1
Yogesh?
defect.
Yeah. As in my practice, I have not done any reconstruction for a type 1 or pure type 1, that is.
Dr. Puri?
Yeah, absolutely the same. I mean, considering I presume most of these fellows have passed through us, they're practicing what we are doing, so I can't afford to be different anyway.
No, you keep trying you keep trying a few options in between. So I thought.
Yeah, so that's more out of, because it's, let me to be very honest, that's more out of boredom and trying to impress the current batch of fellows. But honestly, I don't think most type 1 resections require any reconstruction.
Okay. So for the benefit of audience, I'll just summarize because a few people have sent this question on WhatsApp. Most of us do not reconstruct type 1 resections. And the argument for reconstructing these defects is given that there is a minimal shortening which happens because of small proximal migration of the hemipelvis, which actually in our practice most of the time can be taken care by a little bit of shoe raise. So there is no added morbidity, much morbidity. But if you're trying to reconstruct, then you have two options, either a biological sort of reconstruction where either you use double barrel free fibulas or non-vascularized fibulas, and then you require instrumentation. The disadvantages are that you are definitely increasing the time of surgery. You anyways, pelvis have infection rates anywhere ranging from 15 to 45% in various series. So you are exposing your patients to a longer surgical time, and then you are increasing the chance of resection. These reconstruction obviously require inserting pedicle screws in the sacrum and in the pelvis. Those again can have some complications also. Few of the European countries, when I was speaking to them, they have started reconstructing these defects with non-biological sort of reconstruction, where the hypothesis why they do is they do pedicle screw and two rods, and they put a lot of antibiotic cement into the cavity. So the rationale what they say is that the cavity will be filled, seroma formation will be a bit less, collection will be less, and antibiotic cement there will provide local antibiotic. But there is no proof, there is no study to substantiate that. I'm just giving you their views. But in Tata Memorial Hospital, as well as the colleagues around, we do not do these reconstructions. So this was to summarize what has been the literature there.
No, and the perceived reason for doing these reconstructions is that the tilt in the pelvis causes scoliosis, backache. I mean, I guess I'm almost at the near end of my surgical career, and I still have been fortunate not to see this sort of scoliotic tilt or the backache that has been there. So it's there theoretically existing, but we haven't actually seen that practically in our patients.
Yes, and that's why I mentioned that these patients do have little bit of shortening, which is like easily managed with shoe raise. At this point, I would also like to take a comment from Professor Vivek Ajit Singh, a dear friend from Malaysia. And he has been a very sincere witness of all our academic activities. Vivek, what are your views, and what do you do these reconstructions or not?
Yes, good evening, Ashish. Good evening, Ajay. Thanks for letting me join this broadcast. For us, we do reconstruction for all type 1 resections unless there's a small bridge left, a bridge of bone left behind. And the form of reconstruction that we do is 2 pedicle screws over the acetabular regions, 2 pedicle screws over the sacrum with a single thick rod. I've gone away from using double rods because there is hardly any place to put double rods in this kind of reconstructions. So far, we have done around 12 cases of such, out of which only 1 has failed, where the rod has broken. And in that case, I noticed that we use the 5mm rods. So now in the future reconstruction, I try to get the thickest rod possible. That is a 7mm rod.
Vivek, any issues with not reconstructing these defects?
I wouldn't know because we reconstruct all our defects.
Okay, so you have it. So maybe this is gonna be a nice study where we can look at the functional outcome of these patients. Maybe that may be a food for thought. Okay, so now let me go further to our panelists and ask them that in a P2 resection, what is their preferred modality of reconstruction and specific reasons for it. And I think I'll start with Vivek.
For P2 resection,
Yes.
We started off by using
Vivek.
Yes.
May I request you to switch on your video if you can?
Okay. Well, let me go to a brighter place.
I really don't understand Ashish's fascination with having to see everybody's face. The voice itself is damn good enough. But anyway, I mean,
okay.
I will tell you in
organizing
person.
this meeting.
I will tell you.
Okay, can y'all
So
can y'all see me? Okay. Okay, for type 2 resections, generally we started off by using customized pelvis from China, but we noticed that one, cost is an issue. They cost a lot, and second thing is after resection we found that sometimes fitting them is a problem. So we devised another way of reconstructing where we use this Harrington reconstruction principle. I use an APC, an anti-protusion cage. The one that we use is from Stryker. It's called the Gap 2. After doing the cuts, I will ream part of the ilium to create a small groove where the cage is able to sit into the groove without moving. Then secure it with screws and rods, and we cement the whole thing in and put in a constraint cup together with a standard hip replacement. If the resection is higher, I'll do a slight proximal femur resection and put a proximal femur endoprosthesis to get the length.
Okay, Dr. Puri, your views.
Terrific. Let me bring the video back on again because others are not happy. Yeah. Anyway, so we've gone through the full gamut. When we began, we tried with every reconstruction possible. We've done a bit of extracorporeal radiation. We've done pelvic prosthesis. We've done the saddle prosthesis. But over years, what I've realized is the sort of function that Indian patients need, which is squatting and sitting cross-legged. We've had, I think, very good results within our scenario. Is what we call either a hanging hip or what we call mesh plasty. There's a variety of names you can call that with. And it's basically no reconstruction rather than just lashing together whatever is the residual pelvis left with the proximal femoral head. And today, I think that's been the cornerstone. I mean, if you pick out 100 cases, 95 or more of them would have been, that's how we have reconstructed for type 2 reconstruction.
Great. Yogesh, any different views or it's...
Yeah, as Dr. Puri said, except for extracorporeal radiotherapy and reimplantation, I have done everything. I have done iliofemoral arthrodesis, ischiofemoral arthrodesis. I have used a pelvic prosthesis, but my choice, if you ask me, it's going to be a mesh plasty or a pseudoarthrosis using a mesh. That's a very difficult concept for the Western world to accept. That is what I have realized after having discussions with the other surgeons from the Western centers. But this is what works best with minimum complications, reasonably early ambulation, and reasonably good functional outcome with less of delayed complications related to the reconstruction part. The disease-related complications might be there, but at least you don't have to worry about the implant-related or the reconstruction-related complications. So that's what we are doing nowadays, and with an fair to good functional outcome in these patients.
I think the Western world has also started to recognize that. If you see the last two publications, the one from the Birmingham group for Ewing sarcoma and the meta-analysis, which I think Harsha alluded to during his presentation, that showing that the absence of reconstruction doesn't really compromise functional evaluation too much, and it does add the benefit of reduced complications and reduced operative and post-operative morbidities.
Absolutely, but the American centers are still finding it difficult to accept this. That's after a personal communication with those guys.
Correct. But Trump also believes that if you infect disinfectant, you will kill COVID. So let's take that with a pinch of salt.
Chetan, anything addition or is the same views?
No. After so many years of seeing all sorts of reconstruction in the pelvis, I think we have hit the sweet spot with mesh. I think that gives us the best functional outcome, very early recovery, and least risk of complications. And honestly, it is such a simple procedure on table that after a complex procedure like resection, you are not really struggling at the reconstruction, because believe me, earlier with the arthrodesis and prosthesis, the reconstruction itself is another supra-major surgical procedure by itself with a higher risk of complication. Moreover, we would have to keep the patient lying down for weeks together on the bed, unable to really move much around, not even turn around, and with the risk of bed sores, DVT, all those things add up, and the risk of post-operative complications. Honestly, mesh is miraculous as far as I can see, and I am a strong believer in the use of mesh.
Okay, so
in addition, what you sort of missed out on what I said earlier was, see, the Asian or the Indian scenario requires sitting cross-legged, squatting, sitting on the floor. No pelvic prosthesis or sort of custom-made reconstruction as such would permit you unrestricted motion and safety of that motion if we were to do the sort of reconstructions that what the Western world propagates is required.
Okay, so there is a lot of interest in younger orthopedic oncology colleagues regarding using sterilized tumor bone to do pelvic reconstruction. Chetan, you have any experience of this?
I have done 3 or 4 of them, a couple of them with Mandeep, and one case on my own. Honestly, I'm not too much, a fan of these kind of procedures, because we honestly don't know how this grafted bone will behave in the long run. And I feel pelvis is not a place where I want to go in again and do any procedure, even it may happen 10 years in the future. It's a scary, thought that you may need to re-explore this patient. I would prefer a procedure where the risk of such a thing happening is the lowest. And I think mesh plasty is honestly a permanent solution for this problem.
Okay, Chetan, just let me extend this question to you a bit more. We saw the data from ROH, which talked about midterm results, which were pretty okay for ECRT. But these guys always resurface the cartilage on both sides. They do a total hip. We got recent paper from India, from Hinduja Hospital, which talked about not resurfacing it. So what do you, whatever cases you have done, what do you do?
We have not resurfaced. No.
Okay.
Just used, the sterilized bone and just articulated the hip again. That basically is because of the Hinduja experience.
Okay.
I mean, and Dr. Subin, our colleague from South, he is one of the other guys who has done quite a few of these ECRT pelvis with articulation without, replacing the joint.
Okay,
and
so I think
so
it would
far,
be nice
so
to
good.
speak to Subin to look at the midterm outcomes of these patients. Prakash, can you shed some light on what is the policy in Toronto? They do have access to a lot of allografts, and what sort of reconstructions are happening in Toronto?
So the primary goal for most pelvic surgeries is to minimize risk, and the overwhelming majority would not undergo any prosthetic reconstruction and would have pseudoarthrosis pretty much on lines of how we practice at TMH. The only exception is a lot of thought is always put in place for periacetabular resections, especially because there's a complex hip team. And I've been a part of quite a few surgeries where even if there's been, exactly like Dr. Vivek Ajit Singh said, that complex hip revisions where you've used trabecular metal or revision cages to bridge the defect between the remnant ileum and the remnant pubic area, to reconstruct small acetabular defects have been done in patients where the soft tissue component was not huge, where the remaining muscle cover over the implant was likely to be good, and there were young patients who had at least 2 or 3 decades of active life ahead of them. So to summarize, the primary aim would be to minimize risk and not reconstruct, but a few periacetabular defects would be reconstructed.
Okay, great. Dr. Puri, my next question is to you, and it is specifically about post-operative rehabilitation. A lot of people have confusion regarding, these are complex surgeries, and specifically if you do a mesh plasty, then what sort of rehab protocol do you follow? And do you have any special guys who are trained to rehabilitate these patients, or any physiotherapy colleagues are good enough?
Ashish Gulia. So anyway, but having said that, now rehabilitation in the pelvis, irrespective of the procedure you do, is basically aimed at 2 initial things. One is prevention of pulmonary complications, and the second is preventing a bed sore. So you can't have the patient lying supine in one particular position, irrespective of your reconstruction. You need to ensure that changing position is sort of becomes the rule, and it is followed rigorously. Also, pulmonary physiotherapy is quite intense, because these are patients that have had prolonged surgery, maybe multiple blood transfusions, and could be, say, for a chondrosarcoma, etc., elderly patients as well. So you need to ensure that pulmonary physiotherapy is put in place. The purpose of a mesh plasty is, why do you use a mesh? It's basically so that it forms a firm fibrosis around the reconstruction that you have constructed. So till that firm fibrosis is formed, we would not like gravity acting on our reconstruction. That means we do not allow the patient to ambulate with gravity acting at that particular site. So we turn the patient, Ashish is looking at the clock, we passed our time. So anyway, so we allow the patient to either actively turn in bed, sit up by the bed, practice active quadriceps, but we don't allow them to ambulate with gravity acting. It's only after a period of between 6 and 8 weeks that we would allow them to ambulate on crutches or on a walker where gravity is acting on that. Anything else? I mean, I'm happy to take if there is a specific question about it.
I thought you could only read my mind when I was in front of you. I never knew it happened through video call as well. Okay, so Jamin has asked a question, and I'm going to refer it to you. Is trochanteric osteotomy preferred in internal hemipelvectomy? If yes, when? Indications for trochanteric osteotomy.
So we don't really do I mean, it's a sort of very ambivalent question. Is trochanteric osteotomy preferred? Yes, I know of surgeons who would prefer to do a trochanteric osteotomy because they use an Ollier's approach and they think it gives them better exposure of the pelvis. Do we use a trochanteric osteotomy? No, very, very rarely would we use a trochanteric osteotomy, because I don't think that in any way sort of based on the incision that we are using really increases our exposure or stuff like that. So we have not really used an trochanteric osteotomy. And more so because we do the pseudoarthrosis. For those that are reconstructing the pelvis with a prosthesis and want abductor function, if they can retain that to be acting on the proximal femur when they put on a prosthesis, yes, you could do an osteotomy, wire it down again like you used to do for channels, etc. The sort of reconstruction that we do, I don't think that's necessary.
Dr. Puri, one more question quickly. Somebody's asked, where do you prefer radiotherapy and where do you prefer reconstruction in metastatic disease of bone affecting the pelvis? That was one of the questions. I think we'll just quickly answer that.
Because of the logistic reasons that we have, we don't operate any metastatic cases. So I would be very, very reluctant to recommend aggressive surgery in a metastatic pelvis. The only reason could be where there is an isolated single skeletal metastasis in a patient that potentially has good prognosis or long-term prognosis. If I'm convinced that that surgery is not going to add too much of morbidity and we may actually be impacting the survival of the patient, that's where I would recommend surgery as such. Otherwise, radiotherapy, I think, as a measure in metastatic pelvis is good enough. I know there have been a lot of surgeons who've done the Harrington procedure, etc. So it's an individual decision, but I think the best balance is you're trying to retain the patient's quality of life. You must remember that in metastatic disease, by doing surgery, you are not improving survival. So it's a balance of getting the patient ambulation with the risk that you're going to offer him with surgery, and that's a call that you need to take.
Primary tumor and the prognosis and will
absolutely. I mean, for a lymphoma or a myeloma, would you offer the patient resection? No, that's something that can be adequately treated with chemotherapy and radiotherapy.
Okay. Yogesh, quickly, now we are looking at new technologies coming up where we are trying to utilize newer technology to aid us in resecting these tumors, ensuring a cleaner margin and maybe less morbidity. Your take on it, and then we end the session.
Yeah, newer technology, I think two things coming up in pelvis. One is already in use, and that is the use of navigation intraoperatively. Definitely has improved the need of having an extensive approach, and has improved our accuracy as far as the margins is concerned. But the con is the availability of the workstation and the software. That is not something that is very easily available to all the centers. And the other thing that I see coming in is the use of 3D printing and use of CAD/CAM, so as to have models of the pelvis and design our prosthesis if we are planning to use a prosthesis, and or rather apart from the prosthesis, design our jigs so as to use them intraoperatively while doing the pelvic osteotomies. Now that is something else that also coming into vogue, and we are utilizing that in fact more often than using the navigation. That has improved in our understanding of a proper osteotomy. There is no eyeballing during the surgery, and it's helping us in giving us a good properly planned osteotomy as we have planned preoperatively.
Okay, Dr. Puri, we know that Tata Memorial Center has started doing navigation guided pelvic resections almost now for 50 months. So what has been the early learning points and the lessons, and where do you see its usability in the near future? How it can help us more?
So there are two parts of this question. One, do I think is navigation required in every pelvic surgery? No, I don't think it's required in every pelvic surgery. It's required in select surgeries where you're trying to maybe either save the acetabulum, take very close cuts, or you're trying to resect the sacrum or not. In TMH, we've reached a fairly large number because we've tried to use it for every surgery so that we want to shorten the learning curve in terms of time. Was it indicated in all the 25, 30, 40, 50 cases reviews? I don't think so. But that's just purely to pronounce our learning and sort of reduce the learning curve that we used it. So there is definitely going to be a role for navigation, both in terms of lesser exposure and lesser morbidity of surgery. But because we do not reconstruct with custom prostheses or other fancy gadgets, for us, the role is going to be relatively limited. It will be more in surgeons who have to have very precise cuts because they're going to have custom-made implants that fit in over there. In our scenario, it's only going to be a question of whether we're going to be able to save the acetabulum not by using navigation. When we are going through the sacrum, are we going to be able to save a particular sacral nerve root rather than have to sacrifice it, which we may have done had we not used navigation. Also, as Vivek did mention, in type 1 pelvic resections, sometimes by using navigation, we can still preserve a pelvic rim rather than having to take out a full segment of the ileum. And preserving a pelvic rim is obviously going to improve the function because you're not going to have that residual shortening that is going to occur. So in our scenario, I feel that's the role of where navigation is.
Thank you, Dr. Puri. So I think with this discussion,
Ashish, I think there's one question that has been popping up repeatedly about can the perineurium be taken as a margin?
So I did not include it intentionally because I think this is a concept about not just in pelvis and everywhere, but I think.
No, but I think we need to address this because this gentleman who is Manish Jethani seems to have this doubt repeatedly. The pelvis is different from the rest of the extremity. So far, in our experience, we've never had a sciatic nerve that is sort of stuck and you need to take the perineurium. It's the sciatic nerve is either involved in the tumor or not. It is not something like the rest of the distal extremities where you can take the perineurium to save this thing. So in the pelvis, I don't think this question is really very valid. If you have to cut the sciatic nerve, I think most of us would not do a limb-saving resection because without the sciatic nerve, though there are reports that say that function can occur, when you're taking off the sciatic nerve and the hip, I don't think there is much of a role for limb salvage. But especially in the pelvic area, I think there is little role for resection of epineurium and saving the sciatic nerve because the sciatic nerve is either completely encased by that tumor If it's displaced, then you can adequately save it off and separate it out even without having to cut the epineurium.
Great. So I think we had great discussion, and I would like to thank each one of you who joined us on Zoom and on Ortho TV and viewing us on YouTube as well. I would like to thank all of our panelists, and especially Professor Puri for being part of this session and moderating and giving his wisdom tips. Thanks to Professor Yogesh Panchwag, Dr. Chetan Anchan, Dr. Nayak, and Professor Vivek Ajit Singh from KL to generate a nice discussion. This is the schedule. Yogesh, it's visible, right?
Yeah, it's visible.
Okay, so this is the schedule which we had planned. So next class is gonna on 28th of April, again, same time. We're gonna discuss in detail about biological reconstructions, which are done for reconstruction of tumor defects. And that will be the end of the lecture series. Followed that, we will have two case presentation. One will be soft tissue sarcoma and other will be a bone tumor. As I mentioned you last time, on 1st of May, we one of the topics which we had to delete which was replaced by management of malignant bone tumors, that is the giant cell tumors. We will have that session on 1st of May in the evening, and around same time we'll let you know the details, and hopefully we will be able to share more knowledge with you. So once again, thank you for joining us. Thanks to all panelists and everyone. Thank you so much.
Thank you.
Thank you.
Thank you.